The term stem cell I don't think is well defined. When people say that, there's so many different types and flavors of stem cells that you really don't know what you're speaking to when somebody just says, I receive stem cells.
Dr. Christopher Meadows is a physician at Clinic 5C, founded by the renowned plastic surgeon Cameron Chestnut. He is here today for a deep dive into regenerative therapies, focusing on stem cells.
We're getting stuck in this cycle of injection, 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 and then it's just a bridge to surgery. With this space that I'm in, we are now having an opportunity to say, well, gosh, maybe we can just take advantage of these healing properties and the healing cascade. Isn't there like a middle ground here where I can actually do something that's not only improving pain and improving function, but also has this propensity to regenerate and doesn't have the toxic effects of a corticosteroid injection?
Hi, my name is Chris Burris. I'm a longevity expert and the chief scientist at a lab focused on a longevity molecule. My primary focus is to help people live longer and better lives with science. Make sure to subscribe and share so you and your friends can live longer and better, well, actually, so you and your friends can live beyond the norms. Hi, and welcome to the next Live Beyond the Norms Health and Longevity podcast episode. Our next guest has the best first name. It is, of course, Christopher. Dr. Christopher Meadows is a physician at Clinic 5C, founded by the renowned plastic surgeon Cameron Chestnut, whom I interviewed previously, and you may remember he is a plastic surgeon who takes a significantly more holistic and I would say kind of biohacking approach to achieve his goal of providing personalized, comprehensive, and integrated care so you can look, feel, and perform your absolute best. Dr. Meadows is a physician with 2 board certifications, one in physical medicine and rehabilitation, and the other from the American Board of Electrodiagnostic Medicine. He is a clinical assistant professor at Washington State University. He holds licenses in both Washington State and Idaho State. He has authored and contributed to numerous publications and presentations. He even served as chief resident in medical school. I may be kind of describing that slightly inaccurately. He is here today for a deep dive into regenerative therapies, focusing on stem cells. Dr. Meadows, thank you so much for joining us today.
Awesome. Thank you so much for that warm introduction. Yeah, I'm in good company. Chris is a good name.
All right. So before we jump into your area of expertise, I want to go a little bit further. I actually want to go much farther back. Before there was a Dr. Meadows, even farther back, when it was just like, what was it growing up? Little Christopher, where did you grow up? What were your parents like? If there was some event or someone you could pinpoint as the reason you would ultimately become a double board certified physician, what or who would that be?
Yeah, absolutely. So I grew up in Southern California. I got introduced into the healthcare industry because my father actually was a ski patrolman at one of the local ski resorts down in Southern California, Big Bear Mountain, if you've ever heard of that. And I had the awesome opportunity to be around him when he was doing these ski patrol runs, and I could actually just hang out in the little bungalow at the top of the top of the ski lift, and I could just kind of shadow them, and I could go on runs and kind of follow them down on the mountain. And so I got exposed to various sorts of injuries on the ski lift and some medical types of injuries and emergencies, and I just really enjoyed that aspect. So I had an initial kind of introduction to healthcare, and that's where things kind of started to bloom. But my real passion at that time was sports. I was involved in sports. My family was a heavy sports background, and so it was always, you're going to do something after school. Pick what that is, because you're not just roaming the streets. Find something that you enjoy and get after it. And my older brother was a football player, so I was just like engulfed in sports and really enjoyed that. And I was actually pretty good. I was doing well, kind of to surprise of myself. And some coaches actually started to recognize that and pour it into me. And that's when I started to recognize, although I'm pretty good, I actually have to work at this if I want to stay at the top of this game. I have to, work out on my own. I have to practice my craft. And that's what I started doing. And that's where this idea of performance kind of started to fire in me. And I started to recognize that there are things that I can physically do to help me become a better athlete on the field or on the court. And so that's where things generated. But yeah, you spoke to, are there any specific events? Interestingly enough, when I was in the 7th grade, I had my first major injury. So I broke my wrist, and it was in a football game. And so that was a big kind of wake up of like, gosh, man, this is no fun. I don't want to be injured and on the sideline. It hurt me emotionally. And then come around the following year, I had another injury. I broke my arm. And then one more time, 3 years in a row, I had another injury and I broke my collarbone. And these were just sentinel events that were just so impactful for me. But what really hit me was I had a conversation with my dad, and my dad being in the healthcare space a little bit, he was telling me, he said, I saw this paper, this article, or maybe a news front, I don't recall what it was, but I saw this thing where, drinking soda actually impacts your bone health. Do you think about how much Coke or pop you drink? And I thought, no, I have no idea. I mean, it was for the first time that somebody had introduced to me the idea that how you eat, again, we talked about physically the performance of exercising outside of the sport, but now this idea of you actually have to pay attention to what you're eating because that could impact you. And it was since then that I haven't had a soda since, actually. So this is, I'm 12 years old, and I haven't had a soda since that time. And so these were some of the sentinel events where it started to frame a mental kind of fortitude of sports performance and taking care of yourself on and off the field, and what you put into your body has impact. And that's what brewed into this idea of, gosh, well, I just really love the healthcare side and I want to prevent injuries because I know how impactful that is. But I also like this idea of we're performing both not only on the sporting field, but also in life. And we want to be really maximally performing in all things, not just the sport, but in school or in work. And so that's where that started to brew. And I knew if I wanted to be really at the top of the knowledge peak of human medicine, that it would be medical school would be the route to go. And so that's when I started to pursue, got into college, continued my athletic career into college, but then realized that I really wanted to get into medical school and started to shift my focus in that direction.
Okay, so that was kind of my next question, but I want to slow down a little bit here. So despite the injuries, like 3 years in a row, you're still going back on the field. So like this was a strong passion of yours. That's pretty cool. I have a similar soda experience. It happened for me in my kind of late 30s. I was having training for a half marathon. I was having some calf cramping problems, and a chiropractor who basically just did deep tissue massage to break up the calf. It was extremely painful and very effective. At one point, she asked me, how much water do you drink a day? And I was like, well, how much does a Diet Coke count? And she goes, -1. And I was like, well, I have -6 waters per day. Because at the time I was drinking like 6 Diet Cokes. I'm not as good as you. I do have one on occasion. It's probably once a quarter, maybe. So, 4 per year. But yeah, it's a similar story. Like, hey, yeah, this is probably not a great idea. We should back off of that.
Yeah, exactly.
So your undergraduate degree, physiological science, you already, as I just heard again, already knew you were going to go into medical school, but you're also pursuing athletics, right? You were on, I guess, where were you going to school undergraduate? Because I think you went on to medical school in Michigan, but
Yeah.
what you were also pursuing athletics. Like that's a pretty heavy load. Talk a little bit about that.
Yeah, exactly. So, of course, when you are a competitor and you're in the sporting world, you're always thinking about the next level, right? I want to be able to play. When you're a freshman, you're thinking about starting on varsity. When you're a senior in high school, you're thinking about college. When you're in college, you're thinking about professionals. And that was always my mentality. That was my approach of, I want to get better for the next level. So, of course, I go into college with aspirations of being in the NFL because I played college football. So that was my sport of choice. And yeah, alluding back to the injuries, there was nothing that was going to keep me away from getting back out there because that was my passion. But yeah, then I was dealt with kind of a difficult kind of set of cards in college where I was going to school at UCLA. I played football there at UCLA, and I was in a major that was very competitive because the physiological sciences major is really geared towards medical school. So over 50% of the people in those courses or on that major are on track to go to medical school. So very, very bright individuals. And so now I'm finding myself in this tension of, gosh, I really want to spend a lot of my time training as I know I need to because I want to get out there and I want to compete at a high level and I know I need to improve. I'm not at the level that I want to be at. But the same is true on the academic side, right? I still need to study hard. I need to put a lot of time into the academics. I need to get the grades and the test scores so that I can make myself as a prime a candidate as possible. And so there was tension there. And because, you're in this fate where you can't, there's only so many hours in the day. You can't do it all. So I'm trying to balance these as best I can. But I started to recognize that even if I had a chance to play at a higher level of sports, those careers are really short. They don't really last a long time, or generally speaking, they don't, aside from Tom Brady and some of these really amazing athletes. But generally speaking, the athletic career starts to kind of come to an end. And so I had that foresight, and I knew that I really need to pour into the career side and kind of think about what my future would look like on that. So I stepped away a little bit as far as training from the sporting side, and I poured more time into the academic side. And, so I knew that my career was coming to an end when I finished up at my undergrad at UCLA. And then my eyes were just honed in on medical school after that.
Very cool. And you ended up going to medical school in Michigan, right? So like halfway across the country. Talk about, okay, you were chief resident at one point, right? And that's in residency, I think technically. That's not actually in medical school. I think I probably had that description a little wrong.
Yeah.
Talk a little bit about how you got that. I think that's a high honor. Talk a little bit about that. And then walk us through kind of your professional career up to Clinic 5C.
Yeah, absolutely. So yes, you're right. I went to medical school at Michigan State. So 4 years in Lansing, Michigan. And then after that, you do residency. And it's through medical school that you have to now decide on which specialty you want to do. And I chose to get into physical medicine and rehabilitation. So this is a really unique field, and we could talk more about that. But so my residency training was in Grand Rapids, Michigan, and that's where I really focus in on the specialty of physical medicine and rehab. You do 4 years of residency for this specialty. And the idea of chief resident is really where your peers, it's usually a peer nominated position where people recognize leadership skills, they recognize aptitude for carrying the program to another level, trying to kind of accelerate the learning and be at the forefront of new learning modalities, new applications of medicine. Where are things leading? Where is the field changing, and how can we be at the forefront of that? Because it's double-sided. On one side, you want to be at the forefront of what you're offering your patients, right? You want to be giving them the best possible treatment. And on the other end of that, you want to be able to present that to future applicants, so you get high quality applicants that come in to keep that going. And so that's really some of the roles and responsibilities of the chief resident. And I was fortunate that I was elected by my peers to take on that role. And it's usually a 1 year time frame that you take on that role. And so I was elected, and it was really an honor to be in that position, to really be the leader of those residents and to help kind of pave the way for that program, but also the specialty as a whole.
And then, so right out of residency, walk us through kind of how you ended up at Clinic 5C.
Yeah, absolutely. So after residency, I got a job I was here in Spokane, Washington, and I got a job at one of the local hospitals. And so I've been working there for a handful of years, and also, again, actually helped to develop a residency program there. So I was one of the assistant program directors at that residency program. So really, I've always had this knack for academic medicine and teaching, and I really enjoy working with residents and kind of helping kind of form the brains of our providers. So I was excited about that, and that was a role that they had presented to me as being a part of that position. So I went out to Spokane and worked for Providence, the healthcare system out there, where I was doing a blended practice. I was doing some inpatient, so working with patients rehabilitating from neurological injuries like stroke and traumatic brain injury and spinal cord injury. And then on the outpatient side, as you alluded to, I am boarded in electrodiagnostic medicine. So the American Board of Electrodiagnostic Medicine is where we do a special nerve muscle test, where we can look at the health of nerves and look at the health of muscles. And so those were all part of my practice. Really had a keen interest on diagnostic ultrasound and procedural ultrasound, but I had this really broad depth of my practice, and it wasn't necessarily the real focus that I wanted to. And this field of regenerative medicine was always brewing in the background. I had been exposed to it both in medical school and residency with things like PRP and prolotherapy, and I knew that this was an exciting field. And when I finally met with Dr. Cameron Chestnut, recognizing how much he's utilizing some of these in his practice from a cosmetic side, and then us having a lot of mutual interest in that space, but me adding a different flavor to that, where I like to utilize those things on the orthopedic side. So thinking about things like arthritis or tendon related injuries. And so I was presented an opportunity to join his practice and to really spearhead that program and get into a space that I was really the most passionate about, and where I could see kind of medicine changing and be at the forefront of that.
That's awesome. And I know one of the big things is stem cells. So we're here to talk today a lot about stem cells. So let's kind of dive into that. What are stem cells? What types are there? What do they do? And how do we first really kind of start to manipulate stem cells?
Yeah, this is such a good question, and it's not easily answerable, but I'll do my best to try to portray this, because the term stem cell I don't think is well defined. When people say that, there's so many different types and flavors of stem cells that you really don't know what you're speaking to when somebody just says I receive stem cells, right? And so if I could kind of paint a picture of what it looks like. If you think, I have 4 kids, and so I oftentimes, when I go to, their friend's house or something, it's not uncommon to see, you know, um, kind of the progression of a child in like their first picture of their first day of kindergarten, and then first grade, and then second grade, and so on and so forth up until high school. And you can see the maturation and you can see the changes year after year. Stem cells are very much similar. So you start from the very beginning, in which you have, an oocyte and a sperm, the egg and the sperm coming together, and that creates an embryonic stem cell. And then over time, the stem cell starts to differentiate. It matures, it changes. And so those change into a subtype of stem cells. And then from there, those subtypes branch even more. And so you end up with a huge array of different types of stem cells that ultimately go into specific tissues, like the heart. It has a set of sub cells or sub stem cells that are specific for the heart. Similarly, the liver will have a subset of stem cells that are specific to the liver. But there's also a set of stem cells that actually go back. So it'd be like going back to first grade or so. And that's what you may have heard of mesenchymal stem cells. And so this is a subclass of stem cells that are early on in that maturation process. They're not embryonic, so they're adult stem cells. So that's one classification. But they're a subtype of an adult stem cell, which is a mesenchymal stem cell. And why those are popular in my space is because those have been found to be the progenitor cells for tendon, for bone, for cartilage, and for muscle tissue. And so that subclassification of stem cell is mesenchymal. So most people, when they're talking about stem cell, they're talking about mesenchymal stem cells. So that kind of paints the
One second.
broader.
You said it was the progenitor cell, if I said that correctly. What does that mean?
Yeah, good question. Thank you. So when we think about stem cells that are within a specific organ, those we typically refer to as a progenitor stem cell because they're unique to that organ. They're going to be able to support injury, recovery, healing, or just the simple application of remodel. We know that our tissues are constantly being turned over different time periods, but those stem cells are at the crux of that. And so they're they're dividing to remodel the tissue that they're in. But you wouldn't take a stem cell from the heart and put it in the liver because it's not going to be a liver tissue. It's a progenitor cell or an adult stem cell, or even more detailed, a somatic stem cell that is for a specific organ.
So we've got mesenchymal. I've heard it pronounced mesenchymal. Is that a
Sure.
misprint? Or
Nope.
it's just too
Interchangeable. Yep.
okay, good. So there, because you guys don't want to keep it simple and just have one pronunciation.
Exactly.
Right. So those are adult, and then you get into kind of more progenitor, if I'm saying that correctly, and those are when they're or maybe mesenchymal are also like if it's already geared and it's a stem cell geared to be a heart cell, is that a mesenchymal or is that like an advanced? Is there some kind of adult cell that can become anything and then it starts breaking down from there?
Yeah, that's a good question. And so in the traditional sense, no, that there you would have to reprogram it, and that gets into a different class of stem cells, which would be inducible pluripotent stem cell. So that's another technology where you can in fact take a tissue, usually from the skin, like a fibroblast, and you can introduce what's called the Yamanaka factors. And maybe you've heard of I'm sure your viewers have heard of Yamanaka factors. So these are a group of transcription factors that you can introduce to a cell that actually takes it earlier on. It's like taking that 17-year-old or 12th grader picture and reprogramming it and taking it back to first grade, for example. So that's that reprogramming by introducing these transcription factors and taking an adult or a progenitor stem cell or even a somatic cell and taking it back such that it can act more like an earlier stem cell. And in that case, the idea behind that is if I can take it back, then maybe I can set it in an environment where I can have it develop to go down a different route. And now I can have it become a liver cell, or I can reprogram it and then differentiate into a heart tissue. And that's the idea behind inducible pluripotent stem cell.
And a somatic cell, what is a somatic cell?
So a somatic cell is usually used to define a tissue or a cell that has already been differentiated into a specific tissue. So if I take a liver cell, also known as a hepatocyte, that would be a somatic cell. So it's not a stem cell. It's already been divided and it's already has a purpose. It has a kind of a defined, focus or organ that it's becoming. And so it's not a stem cell anymore.
Okay, so I'm going to try and kind of map my picture of this, right? Everyone is aware that skin is sloughing off of us regularly, right?
Yep.
And then we all kind of understand that it gets replaced. I don't think we really think about how it gets replaced. Like, is there a teeny tiny seed or is there whatever? And it's in fact a stem cell that's sitting there and I would guess it's a mesenchymal stem cell that's ready to take the place of as you're remodeling the different parts of your body. This applies to liver, this applies to heart, kind of the right process.
Yeah, exactly right. So every organ in your body has a subgroup of progenitor stem cells that are designed to help remodel that tissue on a regular basis, some more rapid than others, because not every tissue remodels at the same pace, but they are there to help remodel so that it's constantly renewing, and in the case of injury, support the remodeling of that tissue such that it can repair itself.
Okay, and what do you tend to deal with, right? I can imagine you talked about potentially addressing, joint injuries, and maybe there you want to use, mesenchymal that's already predisposed to become tendons, or like, so what do you tend to use? And is there a global treatment where like, hey, I think there is, but that might be very different. But we talk about the different ways you address it with stem cells.
Yeah, absolutely. So the most common conditions that I run into is I'm in the orthopedic space. So I'm dealing with hip pain, knee pain, shoulder pain, low back pain. And the most common disease process that I see by far and away is going to be osteoarthritis. And so that fits under the subcategory of the bigger picture of arthritis. So it's a specific type of arthritis, which generally is age related, right? So it's wear and tear. You've been training for specific sports, long endurance sports, or you've been playing a sport, like football, and you've had wear and tear on your body over time. And the challenge with some of these conditions is that the stem cell population reduces over time, but also the stem cell population in joints, specifically think about a knee, there's cartilage in there. So there's a subtype of stem cells that repair cartilage, but their numbers are not very large. And in addition, you have a space where the blood flow is not very great. So the propensity of these tissues to repair is actually quite low. And so the idea behind this, and historically speaking, in traditional medicine, you've not really had great options, right? This is a painful condition. It limits you from running or exercising or playing with your kids, whatever it might be. And what do we have? We have effectively steroids, right? Steroids would be an option. But unfortunately, they don't really have any propensity to repair. They're great for pain relief. Steroids, we know, can reduce inflammation, they can reduce pain, and they can, they're very effective for those parameters. But over the long term, they actually don't do anything. And beyond that, they're toxic to chondrocytes, they're toxic to the cartilage, and it's toxic to the bone. So it actually creates a catabolic environment. So this idea is, well, what can we do? Is there any opportunity to take advantage of the body's natural healing process? And where can we learn from that to try to apply that as an application to take something that's been notoriously difficult to treat, but actually help it to repair itself? And that's the idea of regenerative medicine. It started with things like PRP, but and I do use some of that, but in the stem cell world specifically, the idea is, well, we have a cell that we know can become tendon, or we know it can become cartilage. what would be the potential of us introducing that cell into that environment to embed into the area or to embed into that defective area and actually now help support that remodeling phase to help it to regenerate that tissue. And that's what the space that I am in, and that's what that's what I do with my patients is we utilize these treatments of stem cells. We put them into the areas where there's injury that usually is chronic, it hasn't been healing well, and we utilize the stem cells to go in there and to support that recovery process. And so back to your question as far as what types, again, so there's again another spectrum of types, and there's one type that's an umbilical cord derived stem cell, and that's really popular, and that comes from the umbilical cord of tissue or the umbilical cord of normal healthy pregnancies, right? So mom and baby, there's a normal delivery, baby's healthy, mom is healthy, the placenta and the umbilical cord are usually discarded, right? So this is something that, after the delivery, the doctor would probably look at it just to make sure everything looks healthy, but usually gets discarded. And so we've been able to look at that tissue and recognize, well, no, there's a subgroup of tissue in here, of stem cells that actually exist in here, and we can actually utilize that technology to help support healing. So that's one source of stem cell, and we call that allogeneic, meaning that it's a stem cell that comes, or it's a tissue that comes from not yourself, but from another human. So it's coming from the umbilical cord of mom and baby. And then on the other side of that, you have the autologous side, meaning there are pools of stem cells within your body that we can extract and then isolate them and actually re-inject them or utilize them with the same idea in mind, that it's going to help with that regenerative process. So those are the kind of the those are the two main types of stem cells that you can use. And then under the umbrella of autologous stem cell, you have two options. There's the bone marrow that houses a lot of bone marrow derived stem cells, and then you have the adipose tissue, and the adipose tissue also houses the adipose derived stem cell. So when you look back, those are the three main classes of stem cells that we utilize.
So bone marrow sounds painful, right? Like maybe it's not, but it just fundamentally sounds painful. Adipose, like where would that be in our body? Like what's the meaning of adipose, and how would you extract that?
Yeah, absolutely. So adipose tissue is, some of us have more adipose than others. Most of the time when we see the external aspect, we're looking at subcutaneous adipose tissue as opposed to the adipose tissue that surrounds organs, which is visceral adipose tissue. So when we do this, we're looking specifically...
Just for clarity, that's fat, right? We're talking adipose tissue.
Correct.
Just fat cells, yeah.
Yeah, exactly. This is all fat. So there's just subclassifications of fat, right? Of course, we're going to make things more complicated, but there's different classifications, of course, and even beyond that, there's white fat and brown fat. So we're in the classification of white fat, and then that subdivides into subcutaneous visceral tissue or subcutaneous fat, and then visceral fat. And the visceral fat is not accessible for a bedside procedure, right? So the visceral fat is deep, it surrounds organs, and hopefully we have minimal amounts of visceral fat. So we're not going after that. We're looking at the subcutaneous fat, which usually is in the frontal abdominal region or in the flanks, so on the sides, or even on the inner thighs. So those are the most accessible sources of adipose tissue that we can get after. And all three of those areas house a number of stem cells. And it's a bedside procedure to get the tissue. It's a mini-liposuction. You use some numbing medication and you numb all the tissue area that you're going to go after. And then a small little liposuction tool that's connected to a syringe that you're going to just aspirate some of that. So there's a little bit of jarring involved, but patients usually tolerate this very well. You're awake during the entire procedure. It's not particularly painful. There's a little bit of soreness after to the site, but for the most part, it's pretty minimal and it's tolerated really well.
Hey, super quick break from the podcast. Hopefully you're loving it. This is a way you can support the podcast and take advantage of a great offer. We're offering 50% off of one of our MCT bottles. MCT is an amazing oil. Add the ESS60 molecule to it. It's even more amazing. All you got to do is leave a review on iTunes. Send us a notification that you've left that review. We'll get you a coupon code. That'll get you 50% off of our MCT oil and free shipping. Back to the podcast. It's interesting because if you were to just ask the regular person, hey, we think there's some value in some of your tissues and we think we could use them to actually help you heal in other parts of your body, I think the last thing people would select is fat, right? Like, because fat is people just trying to get rid of it. Like, so that. Is there any particular reason? Like, how is the fat tissue seem to be better than anything else? And I can imagine, okay, we're not going to peel off skin to try and heal our knees. Like, maybe we've tried that. Like, what is there a logical or I'm sure there's a biological reason for that.
Yeah, well, for starters, it's a large pool of stem cells. So we just know by sheer number, there's a huge number of stem cells. And similarly, in the bone marrow, that's another large pool of stem cells. So just by sheer number, there's a good source in both of those spaces. The other aspect or the other part of the algorithm is the fact that it's easily accessible. You know, we can immediately get it. Contrast that with doing something like trying to go after stem cells from a kidney or stem cells from a liver. That would be much more invasive. And the type of stem cell, going back to this idea of mesenchymal stem cell, that's really the stem cell we want to go after. Again, we don't want to go after a liver stem cell because that's not the tissue that we're trying to regenerate. I'm trying to regenerate cartilage. I'm trying to regenerate synovium. I'm trying to regenerate bone. I don't necessarily want to get stem cells from these other organs that don't have a propensity to divide and become that tissue. So it's kind of nice that it's just set us up for easily accessible, relatively pain-free, and large numbers.
Okay. And I guess so it turns out that the fat the stem cells and fat are of the same they tend to be all be the same class where they do regenerate cartilage and tendons and muscle even. So those are all that's kind of the same class of stem cells.
Exactly. So the stem cells you get from the adipose tissue can divide and become all of those tissues, which again makes it an ideal stem cell for the use in orthopedic related conditions because we know that it has the propensity to divide and become those tissues. So it's a great cocktail of large numbers of stem cells, easily accessible, and also becomes the tissue that we're ultimately trying to heal. So it's just a great opportunity to utilize that tissue, and in the process, get rid of a little bit of adipose tissue at the same time.
I would imagine if you're taking this adipose tissue, you're injecting it, so let's say in a knee, right? Because we're having some cartilage or tendon problems in the knee. You really, one of the goals would be to keep that adipose tissue localized, and maybe there's not that much blood flow where you're injecting. And I think some of your expertise with, I'm going to mess up the name, but like using scopes to actually get to the right target. Like talk a little bit about the challenges of making sure that material stays there so it can actually do its job.
Yeah, exactly. And that is the next phase of stem cell research and stem cell treatment because we know that most of the stem cells that we inject ultimately die. Unfortunately, they just don't live there for very long. So we're going to talking about over 50% that will probably be gone within the first week, and then they're just going to gradually decay after that. So there are a few things. There have been several that have tried to utilize what's called a scaffold, and what that means is particularly in the intraoperative world, where you're actually cutting open patients and seeing directly and doing surgery, you can create different scaffolds of cartilage, of tissue, of fibrous tissue. You can inject some stem cells into that and then put that into the location, almost like a glue, and then that can help to, the idea is that it would help to keep the stem cells around. But ultimately, in order to be in that space, you would have had to subject yourself to surgery. And most of my patients are not really interested in going into surgery. In fact, if we're being aggressive, we're targeting a lot of these conditions early so that we don't ultimately need to have surgery. We can prevent this and kind of stave off surgery as long as possible. So that's a majority of the patients that I'm working with. And so we're trying to be out of this surgical mindset. So on the other side, and the reason why most of these stem cells don't survive is because the environment that they're placed in. So when you look at the synovial fluid of an osteoarthritic knee, the pH is low. There's a lot of inflammatory, toxic inflammatory cytokines like TNF alpha and interleukin 1, and these things are toxic, and that's part of what creates this toxic environment and why the stem cells that are naturally in the joint are not working. It's because this inflammatory cascade and this ongoing suppression of healing. And so if you were to just inject stem cells into that environment, it's toxic to them as well. So they don't really have a good propensity to survive. And that's where I'm creative in my approach, in which I try to prime the joints, or I try to prime the patient such that that environment is more favorable to a stem cell injection. So oftentimes what I'm doing is PRP in advance of a stem cell procedure, because we know that the growth factors and the immune modulating factors within PRP can actually reduce the number of, or excuse me, reduce the number of TNF alpha molecules and reduce the overall inflammatory component of that joint, improve the pH, and that helps to make a more favorable environment ultimately for a stem cell procedure. But we're still playing across the field of regenerative medicine and stem cell procedures. There are different approaches and different techniques to try and create, again, that kind of scaffold to support the embedding of stem cells into the tissue such that they can regenerate. But even aside from that, the benefits of a stem cell injection are really in the signaling cascade that it proposes or that it handles. And so when it gets in, when a stem cell goes into a joint, it's immediately starting to hone in on areas of inflammation and areas of degradation, where it can home in on these locations and start to send the signaling molecules. So even if we're not getting that embedding component, if it's not sitting there and staying for long periods of time and dividing, it's still supporting the existing tissue that's there to help give it that boost that it needs to support healing and to support that inflammatory cascade suppression and improve pain, support the regeneration of tissues. So there's still a lot of benefit to just the introduction of stem cells into that region.
Okay, so this is the kind of crazy conversations I have. You're probably the same. I was actually talking about PRP, by the way, plasma-rich platelet. That's where you take a blood draw, you centrifuge it, and you take a particular fraction of that plasma. I'm assuming part of the reason that you're getting, because these inflammatory, a lot of people tend to be kind of totally full system inflamed, is part of, and I've never asked this question, just thought of it, part of the PRP process, that centrifuging, are you actually centrifuging out a lot of the inflammatory markers? Do they happen not to be in the fraction that you're grabbing?
Yeah, it's not that there are specific inflammatory markers within the blood alone. So even if you're in this kind of chronic inflammatory state, we're not really worried about any inflammatory markers that are circulating in the blood. What we're most worried about is the red blood cells, because red blood cells do tend to be inflammatory provoking when you introduce them. So when you're spinning it, you're consolidating all of the red blood cells into the bottom part of the tube such that you can take out the plasma-rich protein. And then with that being said, if you are in a state of increased inflammation, there might be higher levels of leukocytes, or the white blood cells. And similarly, we can tailor the centrifuge to either tone up the number of white blood cells that we introduce, or tone that down so we can be more specific to the treat or to the condition we're treating. But overall, back to the question of whether or not there are inflammatory markers within the blood that we're worried about, that's not a major factor, and most of that will be consolidated within the red blood cells, and we get all of that out.
Okay. And then part of the conversation was PRP versus PRF, which I just became of this week, which apparently is a potential replacement for like collagen injections. And there's lots of reasons. Part of my conversation with Chestnut was, hey, these injections are probably not a good idea. Like, I don't want to poo-poo on whatever experience you're having, but they don't go away. They just disperse. And PRF is apparently, it's your own body. It's a little thicker, so it can maybe do a better job than I think it's a collagen injection. So that sounds kind of like a matrix that you might want to inject stem cells into, because they might stay localized. Are you playing around with that as well?
Absolutely. So platelet-rich plasma, usually what you do when you are making it is you introduce an anticoagulant. And the reason is that when blood starts to be withdrawn from you, it immediately wants to start clotting. And if you're going to inject it, you don't want it to clot within the syringe or the needle. So usually there's a certain amount of anticoagulant introduced prior to it spinning. But I've been playing around with this for a long time, because I've been trying to find, as you alluded to this earlier, that platelet-rich fibrin is a little bit thicker, and it gets back to this idea of a scaffold. So why might that be important? Well, if there's a little bit more thickness to this tissue, then that could be, again, like a fibrin glue, where we could introduce stem cells into that and help support the retaining of the stem cells and maintain their longevity within the joint, and hopefully embed into the tissue to regenerate. So I've been playing around with that, meaning that I've been testing how much anticoagulant I put such that I can get the most viscous solution but not have problems with clotting. And so I do actually, a majority of the time, even though I call it PRP, most of the time what I'm doing is PRF, and it's just a kind of a little nuance to kind of finding that right viscosity for stem cell support. But in addition to that, and you may have heard of hyaluronic acid is something that's been injected because it has, like you said, it's got some collagen in it, and you can inject that not only for skin, but also into joints. So patients have been receiving hyaluronic acid injections to support. And the idea is that, yes, I'm introducing collagen, but I'm also introducing a really viscous solution that, especially for a weight-bearing joint, well, maybe I'm kind of pumping that up, right? It's like inflating the tire of the car. It kind of just gives a little bit more support. There's more fluid, so I don't have this kind of bone-on-bone type of picture, this feeling. So I'm re-supporting that the viscosity of the synovial fluid. And so that's an added benefit to this, is it's almost like also getting a hyaluronic acid injection because it's got more viscosity, it's a little bit more volume, and it's going to plump up the joint a little bit more to help relieve some of the discomfort that you might have with a really narrow joint space. Again, just kind of separating those a little bit. So there's multiple benefits to utilizing PRF or platelet-rich fibrin, and I've transitioned almost exclusively to utilizing that.
And PRP can be a treatment in and of itself. I mean, I actually tried some more kind of surface level PRP injections for kind of some knee pain and tennis elbow that I was experiencing. Would there be any reason to, I mean, maybe cost is the reason to kind of start with PRP, see how that works, and then go on to stem cells, or we're already in here, let's go ahead and do, because your process makes a lot of sense. Let's clean up the area, let's make it ready for acceptance of the stem cells, and we'll do that with PRP/PRF or PRP/F, and then introduce the stem cells. Do you tend to approach everything kind of that way, or is PRP like your first go-to?
Yeah, that's a good question. And there's so many factors to take into consideration. And oftentimes it's not uncommon for patients to come to me to have already tried certain things, right? So they may have already tried PRP, or they may have already tried a stem cell injection. And that's probably worth another conversation regarding some of the nuances on why I think maybe they were effective or not effective. But there are some, so it goes primarily to the condition, because there are conditions where clearly PRP is the right way to go, right? I mean, they respond well, and it's a one-time injection, and it's just straightforward. And so there's no question on what to do. But there are oftentimes conditions where it's just a little bit more complex. The history is there, where they've tried so many different things. And so we have to be a little bit more specific, or a little bit more tailored to how we approach that. And so it's not uncommon for me to utilize a protocol where I'm using PRF in advance, and usually maybe over the course of 3 to 4 weeks, where we may do a series of injections, again, priming the joint, also on the back end of that, looking at their mechanics, getting them into therapy, looking at their exercise regimen, because ultimately all these injuries have an etiology, right? I don't want to just fix something just so we can get back into the same mechanics and then we re-injure it. My goal for patients is that we're going to treat this one-time series, and we're going to be aggressive with it, and you're not going to need to see me again, right? So we have to always look at kind of the bigger picture of what your general health is, how you move, looking at other lab work and seeing where can we take, even if it's a 1% here and there, where can we take that to optimize the outcome of your treatment? But so those are all the factors. But again, it's not uncommon for me to be working with patients over a course of 4, maybe 6 weeks, tailoring the procedure, kind of making fine-tune adjustments to the PRP, and again, preparing them for a major treatment like a stem cell. That, yes, there's some costs associated with that, and the procedure of mini-liposuction. So it's an event that we want to make sure we're maximizing the outcome and doing everything we can to make sure we're prepared for that, and then on the back end, supporting that on the long end to optimize our treatment. So again, it's just really tailored to the patient and what their history is and how we can ultimately get them to where they want to be.
Okay, so unfortunately, we're running into some time constraint that I have. I think I'm maybe 1/3 through the question. You saw the questions. You probably were thinking, "There's no way we're going to get through it." I'm
Mhm.
always worried that I'm going to run out of questions, and it never happens. So I need to start honing that in. We'll probably offline. I'll probably invite you back because I have so many things that I'm thinking. Just briefly, you think about traditional medicine, right? Steroids, right? That's what they did in the NFL. You just get steroids and painkillers and send them back out there. And then the next level is like you just repair it, right? You take a tendon from somewhere else, you stick it in there, and those were kind of the end all be all as I understand it. And then now we're talking about, hey, I mean, our body has this. I'll share this. I once poked my son in the chest and snapped my little tendon and ended up with what's called a club finger, right? You know that.
Yep. Yep.
Literally, I would lift it up and it would just fall right down. And I was like,
Oh,
okay, I clearly snapped my tendon. And
right.
in my head, tendons don't grow back ever. But it turns out
Yeah.
that they do, right? So that's the whole kind of value of stem cell and PRP and holding my finger. You can't even really tell it was this one. But that was shocking to me that there was actually a solution. I just thought I was going to have a limp last digit in my middle finger forever. Just real quick, and then we'll get to our wrap up questions. You're doing as I picture it, because maybe it's not, because right, you are traditional medicine in a very real sense, right? You were kind of leading as the chief resident, so that is actually what traditional medicine is. But you're also pushing the environment. Like if you look across kind of orthopedics, how many are now using the kind of techniques that you're using? Is it a good percentage? Is it half? Is it none? Because I have to imagine kind of older school orthopedic dudes are still cutting out tendons and sticking tendons and doing steroid shots.
Yeah, yeah, absolutely. And yes, I did come up in the traditional medicine world, and that was really where I started to just have this difficulty of, gosh, I'm not really doing anything to support the patient's recovery. I can take away pain really easily. There's so many good medications and opportunities to do that. But ultimately, what are we doing? We're getting stuck in this cycle of injection, 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 and then it's just a bridge to surgery. And don't get me wrong, my surgical colleagues, they do a phenomenal job. They're great at what they do. And there are some things that just require surgery, right? No doubt about it. So we need to utilize that where we can. But with this space that I'm in, we are now having an opportunity to say, well, gosh, maybe we can just take advantage of these healing properties and the healing cascade. And why can't we just why isn't there like a middle ground here where I can actually do something that's not only improving pain and improving function, but also has this propensity to regenerate and doesn't have the toxic effects of a corticosteroid injection? And so it's definitely more cutting edge. It has some, there are some barriers there that people just say, well, I'm trained in what I train and this is what I do, and I don't really want to change that. And so there's some resistance there, but I think it's gaining traction. I've seen more open-mindedness. I've seen more people start to see, and what it comes down to is the literature is coming out, and there's more and more robust literature. There are more and more patients who are being able to tell their story about how they've benefited from from stem cell injections. And so I think that's softening the field a little bit and opening it up to a broader mindset of, where does this have its application? What space does this fit in? And how can we really start to leverage that and open up that world? So it's not hugely widespread, and probably the other barrier, of course, as we talked about this, is there's still a cost associated with it. These treatments are not it's not covered by insurance, and so most people are paying out of pocket. They're paying cash, and so that all of that creates this kind of cocktail of some still slow to change and slow to kind of maneuver in that space. But it's definitely growing. There are more and more people. I know the residents that I work with, they're getting more and more excited about that. They like working with me and learning about this space. And several of them are coming to me and saying, I want to do something similar to what you're doing. How can I get into this space? So that's the exciting part of this.
Okay, man, very cool. We'll coordinate offline if we can reconvene, because that would be exciting for at least me and I think the listeners. I do have some wrap up questions. They are really longevity focused, and I think stem cells play a role in that. We just didn't even get close to that really, because the conversation was so fascinating. But Dr. Meadows, do you have a target age that you want to live to?
Oh, that's such a good question. And I do think a lot about longevity. I deal with osteoarthritis, which is an age-related disease. So, I'm thinking about that all the time. And yes, there's so many different things to talk about, cellular senescence and that role in osteoarthritis and age-related changes. When I think about this question, I don't think I have a number. I think more on the experiential side of things. I mean, I have 4 kids. I would love to live to an age where I could see them have kids, get married, and ultimately see them have kids. So being a great grandparent is probably the experience that I would love to make it to, whatever age that might be. My youngest is a 1-year old, so I think I have some work to do. But I think more about, I want to live long because I want life experiences, and whatever number that comes out to be, I just hope I'm able to fill it with as much experiences as possible.
So in order for you to have great grandkids, right, and maybe see them so that they could remember you, I mean, you're talking 70 years from now, right?
Yeah, yeah.
Probably, like if
That's probably about right.
So that puts you at
110.
110. I like it. And then do you good, we backed out the math. How long do you think humans can live?
This is like Olympic world records, right? Somebody's always going to be behind it and chasing that number, and they're going to constantly be broken, and somebody's going to just keep extending that. It would not surprise me if in my lifetime somebody got to 130. That would not surprise me whatsoever. The funny thing is, it will be somebody who's not even intending to. It won't be like an American who's been in the longevity space. It's going to be somebody who just stumbled across this finish line.
So some dude in Tuscany who eats bacon every day, smokes, and drinks at least 1 beer every single day for breakfast and dinner.
That's right. That's right. You got it.
What are 2 to 3 protocols, habits, mindsets? Let's call them shortcuts, because everybody likes shortcuts to longevity and a long health span that you would share.
Oh my gosh, at the pillar, the 3 pillars for me at the top is going to be, it's exercise, it's nutrition, and it's sleep. And, there's nothing that you can do that is going to undermine those. So you have to get those right. You really want to pour energy into optimizing those and being most efficient with those. So those are what I talk with my patients. That's how I approach myself, is that those are the big 3 things that you really want to pour in and get right to really maximize your longevity.
Protein is a huge topic right now. It's huge to me. I'm consuming so much protein. I get tired of shoving protein into my face. What's your protein target? What do you shoot for?
1 gram per pound a day.
Yep.
So for me, I'm 180 pounds, and so I try to get 180 grams. The thing about protein that I think about is you'll oftentimes see people who are consuming protein, kind of grazing it throughout the day, just recognizing how difficult it is to get that many grams of protein. I'm not a big fan of that. I think you need to consolidate your protein into 4 or 5 meals a day. If a firm kind of identified programmed meal that has that amount of grams of protein that's mapped out throughout the course of the day, because that's the way you're really going to optimize the enzymatic cascade that comes from protein consumption. If you're just kind of trickle feeding protein along the course of the day, I don't think it has the same benefit. So really define the protein meal, put it in at one time over a defined meal, and then wait till the next meal to consume your next protein. Not as difficult, it's a lot in one meal, but that's where I think there's a little bit of kind of some, not controversy, but misunderstanding of how to utilize the protein, because it really needs to be high levels in a defined meal and then kind of shut that program down into the next one.
Yeah. And I think it's somewhere between 30 and 40 grams, obviously depending on weight, of protein per eating event. That will really trigger muscle synthesis, dependent highly on leucine, actually.
Yeah, exactly right.
What are 1 to 2 things that people get absolutely wrong regarding longevity and a long health span?
Oh gosh. Well, staying along those lines, nutrition. I think nutrition is, and really, to be fair, it's complicated, and I'll take it one more, step deeper. I think a lot of people get fasting wrong. And I think there's this conflating of what intermittent fasting is and what true fasting is, and really identifying what your goals are from each of those. So I tend to define fasting as something greater than 24 hours. So patients will say, I do an intermittent fast, and really what they're talking about is a time restricted feeding. And I know not everybody acknowledges that kind of definition, but the reason I do that is because, being in the stem cell world, there's a clear segregation. I mean, not really clear as if 24 hours is a perfect, time frame, but when you get to 24 hours or even to 48 hours, you're now starting to stimulate the release of stem cells and this process of autophagy, which I'm sure your viewers are aware of, or mitophagy. And you don't get that same benefit, to a smaller scale, but it's not really optimized if you're doing a time restricted feeding. You really want to get over into that 24, 48-hour phase. So when I say I'm intermittent fasting, I'm talking about I'm doing a 3-day fast and then doing it again in 3 months or something like that, as opposed to the time restricted feeding, which is, in my mind, really a tool that's going to help you to reduce calories if you can. And so, if you want to be a caloric deficit, that's great. Time restricted feeding is a great tool to do that. But I think there's nuances to there, and I'm not sure people really understand what they're trying to achieve when they do an intermittent fast or a time restricted feeding. So anyways, that's kind of my nuances to that.
Very cool. And Dr. Meadows, how can people contact you?
Yeah, so they can go to our website, it's clinic5c.com, or alternatively, they can follow me on Instagram, and there's a link in my bio to our clinic website. They can message me directly. I'm on there pretty regularly, so I respond to viewers all the time, and we have these similar types of conversations. So those are probably the two best ways to reach out to me.
And what do you remember your IG handle, or we'll have it in the notes, but just
Yeah, Meadows.md.
Meadows.md. And what in the near future are you excited about?
Oh, I'm excited for the ongoing expansion of the use of stem cells. I think I'm in the space of orthopedic related conditions, but as a bigger picture, my training and background is in neurologic injury, right? Traumatic brain injury, spinal cord injury. Again, we talked about electrodiagnostic medicine being part of my specialty. And I really think there's going to be opportunity to utilize the stem cell technology to help patients that have been traditionally thought of as having an injury that just doesn't recover, right? We think of spinal cord injury as being permanent. Yes, there have been great advancements in technology and medicine to support that, but there hasn't been this overwhelming reversal of injury or this overwhelming reversal of the continuity of nerves. And I think there's going to be some breakthroughs in that space. So I'm excited about that. And I'm excited about where we can continue to grow and learn about how stem cells are helping our bodies heal, and use that on a wider application for longevity, because I think that's around the corner as well.
Very cool. This was an amazing conversation. Thank you very much, Dr. Meadows. You can find him at clinic5c.com and on IG, meadows.md. Thank you so much for joining us today.
Thank you so much. It was a pleasure.
I hope you enjoyed this episode of the Live Beyond the Norms podcast. Make sure to subscribe and follow. Also, make sure not to be that guy, the guy sharing this podcast with people who are not interested in living beyond the norms. If you would like to learn more about the ESS60 molecule, the molecule responsible for the single longest longevity experimental result on mammals in history, a full 90% extension of life, visit myvitalc.com. That's myvitalc as in carbon.com.